All right. Hi, everybody. My name is Sean Jones, and welcome to our Cancer Chat event. It's the second event in our series. It's on colorectal cancer, perianal lesions, and more. And it's hosted by the Duke Cancer Institute Office of Community Outreach, Engagement, and Equity. And now we'll introduce our moderators for today's event.
Hello, everybody. So I am going to be introducing Sean. Sean R. Jones is currently a second-year MPH student in applied epidemiology at the UNC Gillen School of Global Public Health. He is also a graduate research assistant with the UNC Lineberger Comprehensive Cancer Center and a health education associate with the Duke Cancer Institute Community Outreach, Engagement, and Equity Office. Sean previously earned his bachelor's in cultural anthropology and biology from Duke University in 2017 before working in the Duke University School of Medicine Psychiatry Department as a clinical researcher. His passions include tobacco cessation, Black and LGBTQ plus health, and eliminating health disparities in several areas, including but not limited to cancer, nutrition, and cardiovascular health. He ultimately plans to utilize mixed method approaches through epidemiologic data analysis and health education programming to combat issues affecting marginalized communities. Sean currently serves as a community advisory board member for the Duke Cancer Institute and Durham's Community Health Coalition.
Hi, everybody. I'm going to introduce Adriana. So, Adriana M. Parker, MPH, is currently an evaluation research assistant with Abacus at the UNC Center for Health Equity Research, where they work with rapid acceleration of diagnostics underserved populations, coordination, and data collection center. They earned their MPH in health behavior from the UNC Gilling School of Global Public Health in 2022 and their bachelor's in gender, sexuality, and feminist studies and African American studies from Duke University in 2018. Adriana's passions lie in reproductive justice, sexual health education, community-based participatory methods, and health equity. Her wide range of experiences include using arts-based methods to teach sexual health to youth populations, serving as an advocate and crisis counselor for survivors of sexual violence, and assisting evaluation and implementation efforts for various perinatal health projects. They are also trained as a full-spectrum doula and have been supporting birthing people through every stage of reproductive health since 2019. So here's the agenda for today's event. So first, I will introduce the Office of Engagement and Equity, and then I will talk about the purpose of this event, and then we will introduce our two amazing presenters, and then they will present. And then after that presentation, we'll have a Q&A session where you all will be able to ask questions to them about their presentation. And then we will discuss some resources from our office. And then after, I'll tell you more about our next event in the series, and then we'll close out the event. All right. Oops, sorry. The Duke Cancer Institute is the flagship cancer center for the Duke University Medical Center catchment area. DCI is home to over 400 researchers and physicians, and over 66,000 patients are seen annually across 6 locations in North Carolina. In 2012, the Duke Cancer Institute launched its Office of Health Equity in order to better engage with the community and provide outreach opportunities to increase the community's awareness, knowledge, understanding, and importance of engaging in clinical trials and research through a health equity lens. The Office of Health Equity provides health screening and education, health disparities education, community-facing navigation, and clinical trials education. The Office of Health Equity transitions to the Community Outreach, Engagement, and Equity program on January 1st of this year. So for the purpose of this event, so in collaboration with our community partners, we have planned events as part of a series to advance equity for the LGBTQIA plus community as it relates to cancer and other health disparities. This evening's event is the second in our series and is focusing on colorectal cancer, perianal lesions, and more, of which members of the queer and sexual and gender minority communities are at high risk. It is our hope that this event provides necessary information and resources, as well as sparks dialogue within and outside of the community to improve overall health outcomes for this community and other marginalized groups that are disproportionately affected by colorectal cancer and other conditions.
And now I have the honor of introducing both of our presenters for tonight. So Dr. Anna Virapon is a physician at Duke Health who specializes in general gastroenterology. She completed her medical training at Boston University of Medicine in 2011 and completed her residency in internal medicine in 2014. Following residency, she completed a gastroenterology fellowship at the University of California, San Diego in 2017. Dr. Virapan's clinical practice includes a wide array of digestive diseases, including the esophagus, stomach, small bowel, colon, and liver. She has a personal interest in anorectal mammiometry, which is helpful in the treatment and management of constipation and fetal incontinence, as well as hemorrhoid banding. Dr. Billy Wallon is a colorectal surgeon at Duke Health who treats all diseases related to the colon, rectum, and anus. He completed his medical training at Tufts University of Medicine in 2007, and completed his surgical residency at the University of Hawaii and Case Western University in 2009 and 2015, respectively. Dr. Land completed his colorectal surgery fellowship at Case Western in 2016. He has special interest in the treatment of inflammatory bowel disease and surgical management of colorectal malignancies, including anal neoplasms. And now I will pass it over to Drs. Virapan and Dr. Land for their presentation.
My name is Dr. Anna Virapan. Hopefully everyone can hear and see me and see the presentation. So we're going to go ahead and get started. So I know earlier they did an event on colorectal cancer screening. So today we kind of wanted to focus on a different area, but again, welcome all questions. And so today we're going to talk about perianal lesions and beyond. So anorectal complaints are very common in the LGBTQ plus population, as well as the common other population. Hemorrhoid related complaints account for more than this many million outpatient evaluations annually. Many anorectal diagnoses share common symptoms, so sometimes it can be really hard to differentiate what exactly is going on. Benign anal rectal conditions share common symptoms with cancers of the anus and rectum, so that can also be a little difficult. So it's really important when you go see a provider, what history that they'll be asking you and what history you are aware to be taking notes of so that you can provide. So important signs and symptoms that the providers will ask you about include bleeding, any kind of pain. Is it in the rectum area? Is it around the anus? Is there any drainage? Is there any itching, which is what we refer to as pruritus? Is there anything coming in and out of the orifice of the anus? Do you see a prolapse of tissue? Or does it seem like, maybe there's a little bit of a hemorrhoid coming in and out? We'll also ask you bowel habit details, number of bowel movements daily, how many minutes do you actually spend on the toilet straining? What is your cleaning routine? What kind of materials do you use to clean yourself in the anus? And do you use any kind of bowel regimen? And whether or not, you use any kind of enemas or any other kind of things that can sometimes be traumatic to the anus. Other important symptoms, of course, are the ones that we worry about, unintentional weight loss, any kind of change in your bowel habits, any recurrent belly pain. And we always want to ask you, have you ever had a colonoscopy before? Have you ever had a flexible sigmoidoscopy before? Flexible sigmoidoscopy is a half colonoscopy and it only explores the left half of the colon. And the only preparation for that procedure is just 2 enemas. And sometimes people do it without sedation. So it's a pretty easy procedure to do. Then they'll probably do a physical exam. So when we're looking at the anal canal, I'm going to use my pointer here. So this is the anus. This is the opening where the stool comes out. And this whole arrow is the anal canal before you hit the rectum. The anal canal is usually about 3.5 to 4 centimeters long. The dentate line, which is this line, it's wavy, separates the anal canal into 2 halves. So each half is a distinct embryonic origin when you're a fetus. So the half that's closer to the opening actually has sensation. So you can feel when the scope is here, when we're taking biopsies in this area. The proximal half, the half that's closer to the colon, is insensitive, meaning that if you take biopsies from this area, if you do any kind of instrumentation in this area, the patient does not feel it. So when they do an anal rectal exam, they are looking closely at the outside of the anus. We're looking for cancers, any kind of abscesses, any kind of nodules, any kind of fistulas, areas of drainage, external lesions such as hemorrhoids, any kind of areas of skin rashes where we see that people have been itching. And we look for warts as well. We also, so a perianal lesion is completely visualized with separation of the butt cheeks and is within 5 centimeters of the anus. An anal lesion is not completely visualized when the butt cheeks are separated. And so part of it actually goes into the anal canal. This is a picture of the colon, just to understand the anatomy a little bit further. So this is the anus, as we talked about. Here is the dentate line, and distal to this line is where you're sensitive, and more proximal to this line is where you're insensitive. The first 15 centimeters of the colon is called the rectum. And after that is the sigmoid colon. And we have, the distal rectum, the mid rectum, and the upper rectum. Things that we're thinking about when people present with different kinds of complaints. When people say pain, we worry about, is a hemorrhoid potentially thrombosed? Has it clotted off? Could there be an abscess there? Could there be a fissure there? Is there a cancer there? When people come in with bleeding, we worry about some of the same things: fissures, hemorrhoids, typically internal, cancers. We worry about colon polyps, colon cancers, colon inflammation, colon vascular abnormalities. When people complain about a lump at the anus, it can be continuous there all the time, or it can come in and out. We worry about prolapsing hemorrhoids. We worry about rectal prolapse. The provider will most likely do a digital rectal exam after they do the inspection around your anus. You will be laying on your left side, and you will most likely bring your knees to your chest so that the provider has full visualization of your rectum. They will typically, after they do a good external exam, they will put a gloved finger inside, and they will rotate their finger in a full 360 degrees, looking for anything abnormal, masses, any kind of narrowing that could be a stricture. They're also looking for fissures, which can be quite painful. We also assess how well your sphincter is doing in terms of how strong it is. So we'll look at the resting sphincter tone, how well you're just contracted normally while you're resting. And then we'll also have you pretend to hold in a bowel movement, as well as pretend to let out a bowel movement. So we look at contraction and relaxation. Sometimes we'll also do an anoscopy. If you've ever had a cervical exam, we use the same kind of speculum. It comes with a built-in light, and it is about the width of 2 fingers. And we put it into the rectum, and we're able to take a close look at the distal half of the rectum and look for different kinds of lesions. The first thing I wanted to talk about was hemorrhoids. So I think this is very common. As you saw, there's multi-million visits to the clinic every year for this. And this is something that I specialize in my clinic. There's 4 different grades of hemorrhoids. It goes 1 through 4. 1 is just an internal hemorrhoid. So looking at this diagram, it does not cross that dentate line that we talked about. The first line, typically is usually you try to avoid straining, you increase fiber to about 25 to 35 grams per day, you drink at least 65 ounces of water a day, and you make sure your bowel habits are soft. Of course, if any kind of symptoms persist despite this, then we can do banding, which I'll go into further. Grade 2 hemorrhoids are the ones that can prolapse when you strain, and prolapse means they can come outside of that dentate line. Sometimes they can pop out even so that you can see them or feel them. And typically they will retract spontaneously. So when you're not straining, they'll pull right back in. And this can cause bleeding, itching. The third type of hemorrhoid two hemorrhoids, but it's only can be pushed back in by manually, like you have to insert the hemorrhoid back in. It doesn't retract spontaneously. Finally, a grade 4 hemorrhoid is a hemorrhoid that we would all prefer not to have. That is the thrombosed hemorrhoid. It is out, it is visible, it is evident, and it's usually because it's clotted off and it's very painful and tender. So hemorrhoids, I want to talk about thrombosed hemorrhoids first, which are grade 4. Usually diagnosed by appearance. They're very big, they're tender. The patient's usually in a lot of pain. If it could be ulcerated, it could be putting out clot. If it's within 72 hours of when the patient presents with the hemorrhoid, of when the hemorrhoid has developed, we can actually do an incision and drainage of the hemorrhoid to release all that clot and reduce the patient's pain. If it's over 72 hours, usually the patient's already feeling better and you can no longer incise and drain it. We'll just have to treat it supportively and wait till it goes down by itself. These are some pictures of external hemorrhoids. So you can see here, it's definitely enlarged. It looks darker than the surrounding area and it's tender to touch when you do a physical exam. Here is one with a little bit of clotted material here. And this one is actually circumferential thrombosed hemorrhoids. So they're all very big and there's about 4 big columns, and I'm sure this patient is in a lot of discomfort. So symptoms that require hemorrhoid treatment. So indications for treatment would be a lot of bleeding, despite conservative measures, itching, any kind of leakage. Sometimes, so what the hemorrhoids do is they can prevent the anal sphincters from completely closing in on themselves because the hemorrhoids are there preventing the closure. And so you can have a little bit of seepage or leakage that comes through. Sometimes people can also have a pressure sensation, especially people who sit for prolonged periods of time, especially truck drivers. And I've been noticing a lot more as people are working from home during COVID, less walking around, people are dealing with more hemorrhoids. Treatment is in-office hemorrhoid banding, using an instrument that's about the size of my finger. You need typically about 3 to 4 treatments. We place 1 band at a time, and we do the bands at least 10 days apart. It's very low risk, less than 1%, and the most common risks are infection or bleeding. But again, the risk is less than 1%. This is my instrument that I use. And basically I would put the instrument into your anus. It's got a small rubber band that is a yellow thing that's right here. And so my instrument's able to suck up the hemorrhoid into the channel, and then it's able to deploy the rubber band over that hemorrhoid. So this rubber band cuts off the blood supply to the tissue. The head of the hemorrhoid will die off and the rubber band will scar down so that the hemorrhoid is not able to reform. And a hemorrhoid is just a dilated vein. Within a few days, the tissue falls off, and there will be scar tissue that remains in that area. If you want more information about this, we use the CRH O'Regan system, and it's been really good to us with really good effects. Another condition I want to talk about was a fissure. Here you can see it. It's a very, very tiny line, and there's a little bit of white exudate in this area. Typically, primary fissures are from trauma, constipation, diarrhea, vaginal delivery, anal sex. Secondary can be secondary to Crohn's, very infrequently tuberculosis, sarcoidosis, cancer, HIV, syphilis. People really describe severe anal pain, knife-like. They describe it like lightning strikes, stabbing, sharp. It can be present all the time, and it can definitely worsen with defecation when that tissue is stretched. It's a longitudinal tear that doesn't extend past that dentate line. So most best way to avoid these is keeping normal bowel habits, avoiding like excess wiping, diarrhea, constipation, straining, making sure you have enough fiber, again, 25 to 35 grams of fiber in your diet per day, and at least 65 ounces of water per day. Typical treatment for fissures is a cream. So you would take a gloved finger, you would use about maybe like a quarter fingernail of the cream, and you put it in a circular distribution along the anal canal. It increases the blood flow to the area to promote healing. Typically, we recommend at least 2 to 3 times a day, religiously, with a gloved finger, and for at least 8 weeks Typically, after a few weeks, the patient starts feeling better, but the fissure will reoccur if they do not do the full 8 weeks of treatment. And so it's really important to stress that factor. So usually in my practice, if you failed 2 different kinds of topical therapies, then I will refer you to surgery. And in surgery, they take out the fissure surgically. Another thing I wanted to talk about was skin tags. So it's an outgrowth of normal skin. They're pedunculated lesions on narrow stalk, so they can have a little bit of stalk, and then it's like got a little bit of a head. I would say it's in at least 50% of adults. It increases with age. It occurs at sites of friction. So your armpits, your neck, underneath your breasts, the anal area, the inguinal regions. They get symptomatic. They start to bother you when they're traumatized. They're caught on jewelry, they rub on clothing. Treatment is if lesions are irritating or if the patient desires removal for cosmetic reasons. The cosmetic reasons obviously wouldn't get covered by insurance, so it would be an out-of-pocket cost. So unlikely to recur in that same area, the same lesion, but of course new lesions can develop in the subsequent predisposed skin areas that have lots of friction. I didn't have a good picture. Finally, the last topic I'm going to talk about is rectal prolapse. So this is a pelvic floor disorder that occurs typically in older adult women, but it can occur in people of all ages. Risk factors are typically above 40, being female, having multiple children that were a vaginal delivery, any kind of pelvic surgery, chronic straining, constipation, chronic diarrhea, pelvic floor dysfunction, or any kind of anatomic defects. Symptoms are typically bleeding, incontinence, seepage, like people can't control their bowels anymore. They'll have a lot of stool leaking, even though they're not intending to. When they try to evacuate, they feel like it was incomplete evacuation. Sometimes they can feel a mass that comes out through the anus, and then they'll have to push it back in, or it retracts spontaneously. Typically, we diagnose these with an X-ray. We actually have the patient on a toilet, basically trying to defecate, and we are able to see through the X-ray if what exactly is coming through. And the treatment is typically surgery. So this is, I think, Billy's slide. So I will stop screen sharing.
Thanks, Anna. I'm gonna start sharing mine. You want to continue? All right, can everybody see this screen okay? Just let me know if you can't. So my name is Billy Lan. I'm one of the colorectal surgeons at Duke. So thanks for having me and Anna here to talk about some of these topics. So I'm just gonna continue on with what Dr. Veripan was saying, with some mainly anal conditions that I see in clinic that may be a little bit more prone in the LGBTQ plus community. So like Dr. Veripan was saying, for any anal conditions, anal rectal condition, the exam is pretty critical. And Dr. Veripan went over some of this, but I just kind of included some pictures. So whenever you have an issue or you think you may have an issue, the visual exam is the most critical part, rather than, for me, rather than a primary care telling me, oh, they think this patient has this, I make sure that when the patient comes to my office that I see it visually. So there are ways to visualize this, and there's different positions that we put people in. One is the left lateral kind of decubitus, we say. We lay patients on the side, leg up towards the chest a little bit, kind of in a fetal position. In our office, we have a table that's similar to this. It doesn't look as dramatic as this, but we, kind of have the patient then kneel and bend forward, and this kind of in a prone position that we mentioned. So we could have their bottom kind of up in the air that we could see for best visualization. And depending on the patient's body habitus, one of these positions are better than the other. So these are just some of the pictures that Dr. Veripan mentioned, pictures of the instruments that we use that Dr. Veripan mentioned. One is the anoscope, is these pictures here. It's a circular tube that we could put up the anal canal, help visualize the anal canal, as well as the more kind of up higher, if you will, in the anal canal. Depending on how high we want to look, there's different types of scopes, anoscopes and proctoscopes, and there's different names to help visualize better portions of the rectum and anal canal. These procedures and visualizations are usually done in the office, but maybe 90% of the time or so we're able to do this, but in the rare instances, people are having too much pain, too much discomfort, or just don't tolerate some of these instrumentations, and we take them to the operating room to get a good visual exam. So I'm going to start off with talking about a condition called perirectal abscesses. You may have heard about people kind of getting these conditions. Essentially, it's an abscess, maybe something like a pimple that happens around your anal canal. All right, this happens because there's obstruction of anal glands that leads to an abscess. If you look at this picture, there are these things called anal glands, anal crypts right along kind of the dentate line here. These glands get plugged and they develop an abscess that leads to certain types of symptoms: pain, swelling around kind of the anal skin. You might kind of feel it around the buttocks over here. On both sides, you may have some swelling there. When you kind of feel that area, you might feel a lump. Sometimes if the abscess is big enough, you might have a fever. Some risk factors for developing perirectal abscesses are, like what Dr. Virapan mentioned, poor bowel habits is a common thing, diarrhea or constipation, or any kind of anal trauma risk factors that make people more prone to getting some of these conditions. Perirectal abscesses differ based on its location. If you look at, and the symptoms, they vary based on its location too. So if you look at this picture, this is similar to the picture that I just showed you, but with different locations of perirectal abscesses. It could be up high here. It could be a little bit lower where you kind of feel it along the skin. If you palpate your skin as you're touching or you're wiping your bottom, and you feel a little lump there. It may happen in between the sphincter muscles here as well. So all these different types of locations, for these abscesses may present with different symptoms. So some have pain at the anus, at the skin, with some swelling, like this one. Some patients say they just have some pressure, and when you look at their skin, you actually don't see anything because these abscesses are a little bit higher. They might describe some pressure around the rectum. They may describe these symptoms when they're kind of sitting or kind of pushing or having a bowel movement. So it's not always necessarily visible, like this first picture here, where the abscess is visible just at the skin, and just kind of lay the patient in the correct position. Some patients may actually have some drainage. If this abscess has come to a head, then the skin will open up and it'll start draining. You may say there's mucus draining, there's pus draining, things like that. The treatment for these abscesses is actually incision, and making an incision over it and draining this abscess. At times we give people some antibiotics if there's some bad inflammation around the skin, but usually the main treatment, the main way to improve your symptoms is to incise it and drain this. So next topic, condition I'm going to talk about are anal fissulas. What we call them fistula and anal, they're kind of referring to the same thing. A fistula is an abnormal connection from one space to another. So one thing to know is that 80% or so of abscesses will heal without formation of this tract or this tunnel or this fistula. So if you look at this picture, you have the pointer, you see, like I said, these abscesses usually start at these crypts or at these glands, and they find a tract out to the skin, so you develop an abscess here. So once this abscess drains, it could lead to a fistula, especially if this tract doesn't heal. So if you look at this picture, these are potential tracts or fistulas that can form after an abscess has been drained. So you could get a fistula tract that starts from here, going all the way out to the skin that way. You could have a tract that goes a little more superficially. You could definitely have tracts that, track up higher and back down. So there's all different ways that these fistulas can form. And based on the different fistula that you have, it will affect how easy or difficult some of these fistulas can be treated. Some symptoms that you may have if you're suspicious that you may have a fistula is that you may have persistent drainage after your incision drainage. Maybe a month later, the drainage just does not stop. That indicates that the connection from the inside, from here around the dentate line, is open, so it continues to drain stool through this tract, keeping this tract open. So that's indication that you might have a fistula. Or you may have recurrent pain around this area, or especially if you have recurrent symptoms right on the same side. If it's the left side, then the symptoms go away, but then they come back. We have another abscess there. It requires another drainage. And that indicates that there may be a fistula connection, meaning a connection from the inside here to the outside of your skin. If you have these recurrent symptoms, there's meaning that you get treated once, it seems like there's adequate treatment, you get recurrent ones. Then there's also for us physicians, something we always have to keep in mind is this, is this really underlying Crohn's disease or some kind of malignancy there that's preventing these fistula from healing and from having these abscesses recur over and over again. The treatment for these is actually, one is putting in a drain in it. We call it, as a fancy term, it's like a rubber band. We call it a CPON. Like this picture shows, you put a little rubber band along this tract here to help drain out the abscess. So if you had an abscess like this one here, you'll put a rubber band going around it, like this picture, and drain this abscess, clean out this tract. There's other ways to, once you have a fistula, there's other ways to close it, meaning that after the CTON, you'll need a second procedure to try to close this opening, this internal opening, as we call it, because this is where everything kind of starts. You could put a plug something in here to close it. You can put a flap, meaning you raise a little flap of tissue here to plug it up or to cover it up. Or you could try to ligate this fistula tract. All these procedures are described, and certain surgeons may use different procedures to heal your fistula. And of course, the main and one thing we always keep in mind is we need to rule out other causes of why these fistulas form over and over again. Inflammatory bowel disease such as Crohn's, that we always keep in the back of our minds, especially with recurrent fistulas, and other things like anal lesions that you may have, cancer that might be underlying all this. So a lot of times these all the time these procedures are done in the operating room, so we get a good exam of the anal canal there. So next, that leads us into the next topic, which are anal lesions. Mainly anal lesions. We're talking about anal neoplasia. Fancy term is what we call squamous intraepithelial lesions, SIL. They range from anything to an anal wart, an anal coloboma, as we call it, to something that's different grades. So a low grade versus a high grade. The high grade is actually a precursor to cancer. So when we see anybody with anal lesions, I'm bringing up some pictures here in a bit. We are trying to, one is determine what it is, and then try to prevent the progression of these lesions to something a bit more concerning. So some symptoms that you have, like with a lot of these other, anal conditions, it's not very specific. It could be ranged from pain, some bleeding, some people get some burning, itching, and you could probably recognize that some of these terms that Anna described for hemorrhoids and fissures, they're all very similar. Some can also be asymptomatic. So when you feel something on an exam, when you feel something abnormal that's persisting, it's key to get an exam by a physician. Some risk factors for developing anal lesions. HPV virus, human papilloma virus, HPV, many females know about this, and we all know about this because it's something that it's a gynecological issue. It causes cervical cancer. So females usually get pap smears often. And for anal lesions, the etiology is the same. It's often caused by this virus, the human papilloma virus. Anybody who's immune compromised. Usually these viruses just kind of stay on your skin. They don't cause any problems. For people whose immune system is compromised, these viruses may start acting up and create lesions, starting with wars that can progress to something else. These other higher grade lesions. So people who are HIV positive, and I'm not necessarily saying just people who are HIV positive that are well controlled, meaning their CD4 count is high and low viral load. I'm mainly talking about HIV patients who have poorly controlled disease, low CD4 count, high viral load, things like that. Females, especially if they've had a history of cervical and vulvar cancer, because these malignancies are caused by the virus as well. So if you have had these conditions before, then you are at slightly higher risk of getting, anal lesions and anal neoplasia as well. People who engage in anal receptive intercourse, these patients have a slightly higher risk. People who have multiple sexual partners, and this I'm not just talking about, male to male or female to female. Any kind of sexual partners of what any gender increases your risk of contracting some of these, this issue. And smoking is another risk factor that's been described over and over. So anal neoplasia, again, these are pictures on the right here, is showing the different presentations. It could be small little discoloration that you may not even feel, or you may not be able to see. There's some who have some maybe like a little skin breakdown that causes some discomfort and pain when you wipe or go to the bathroom. Again, some of these are very subtle changes, and otherwise some are a little more obvious. These little whitish plaques that develop. And especially if you notice these things that aren't going away on its own or over time, then it's something that you should seek professional help for. In terms of screening for anal lesions, there are no set guidelines that are well established out there. The screening tool that is being used is an anal pap smear, similar to a cervical pap smear that females undergo, meaning you just put a little brush here, kind of try to pick up some of these cells and look for abnormal cells. That's the screening test, but there isn't a good, there aren't guidelines as to what age we should start, screening people, what frequency we should start screening people. So those are all kind of dependent on kind of the hospital you're at, the institution you're at. So there's some discussion, should we be screening all high-risk patients? The patients who have elevated risk factors, like in the slide I showed before, those patients that we should, use some type of use this type of screening tool to prevent a progression of these anal lesions to something a little more concerning. Treatment for these anal lesions, one is mainly you need to confirm it by a biopsy. You need tissue sample to confirm that this is what you think it is. Because, trust me, a lot of these lesions can look like something, but sometimes you take some tissue and it's not. It's just maybe a little hemorrhoid, a little skin tag, or a fissure that appears to that has an appearance of something like an anal neoplasia. After you diagnose it, then the next step is try to remove it. There are creams or topical ointments that you could place on these lesions. Sometimes they don't work. So then the next step will be trying to remove it surgically. Fulgurating it, meaning is this a fancy term, is trying to either burning it off, using cautery, electrocautery, or freezing it off. And the opposite, these are all options. If lesions are too big, let's say, then burning and freezing is not an option, then we would, take somebody to the operating room that excise these lesions. Meaning we make little cuts around this, we try to cut it out and then send it to the pathologist. The goal for treatment for anal neoplasia is not to eradicate the virus, but control the progression of these lesions that pop up. We don't test, especially in our office or for Duke Colorectal, we don't test people for the HPV virus, HPV. We are mainly going after the lesions that pop up, such as the ones that are shown in this picture. So the goal is to eradicate these lesions and keep them under control so they don't progress. rather than, treating the virus, because surgically you can't, treat a virus. After the diagnosis and some of the lesions have been removed and disappear, the next step is surveillance. We need to keep an eye on these things. So normally we have people come into our office, somewhere around, every 3 months to a year, based on your different risk factors, for an exam in our office. So last thing I'm going to talk about is anal cancer. So these anal lesions can progress to something cancerous, so something called anal cancer. And the term we use is anal squamous cell cancer, just the type of cells that are found in the anal canal. So that is what we are all trying to prevent people from getting. Again, a diagnosis is needed via biopsy. So you actually need tissue samples to confirm the diagnosis. Physical exam includes everything I just talked about with the anoscope and all that, but we also palpate, make sure we palpate the people's groin on both sides, because that's where the cancer can progress into the lymph nodes, and the first lymph nodes are in your groin. So we ask people, hey, have you felt any abnormal lumps or bumps in your groin? And then we would examine and palpate that area too to make sure there is nothing abnormal. Next step will be getting some kind of an imaging. Usually we do a CT and PET scan to see if there's any lymph nodes that are abnormal outside of the anal canal, like in your groin or somewhere else in your body. One good news is that the treatment for this is usually not surgical. Usually it's radiation and chemotherapy related. So you'll see a radiation oncologist, a medical oncologist for this. And surgery is not indicated for anal cancer unless there's a recurrence. And after all this is treated, you'll need to undergo surveillance for anal cancer, with the oncologist, with the surgeon, to make sure no new lesions pop up. There's no recurrence. Great, thank you.
All right, thank you so much. We really appreciate you guys coming to share that information with us. So next up, we will have our Q&A session. So Adriana, would you like to start us off with the first question?
Yes. So in terms of screening for anal cancer, are there specific guidelines for the LGBTQIA plus community in terms of how early and how often?
There are no guidelines that are set out there. So certain institutions will do different things, and definitely Duke does not have one set in place. And that's just based on, literature and studies that have been done that, starting screening at a certain age has not been beneficial. So our process is, we don't have a screening process, but if we do see these patients, usually by the time I've seen these patients, they already have something. So what we usually tell people is just you have to be kind of vigilant and keep an eye on things yourself. If you notice something abnormal, especially if you are in a high-risk population, HIV positive, and all those other risk factors I mentioned, then I tell patients themselves keep a close eye. Once they have something, then how frequently we survey them or have them come into my office varies too, based on the risk factors. So if you're a low-risk patient, I have them come back maybe 6 months for a year or two, and then you don't need to see me if there's nothing new. If you're a high-risk patient who's immune compromised, maybe HIV positive, that's not well controlled, then I have them come back to your office, every 3 to 6 months for several years for surveillance. So yeah, there's no screening set guideline out there as to what age and what the frequency should be, unlike maybe like colon cancer and colonoscopy and all that stuff.
All right. So what precautions should queer individuals who have anal sex take to help prevent perianal lesions such as fissures and hemorrhoids?
I think that's a great question. So I think in order to prevent fissures, I think definitely there should be some lubrication involved. And so as long as the area is kept nice and moist so that there's not friction on a dry surface, I think it should help. And then for hemorrhoids aren't necessarily caused by anal sex. Hemorrhoids are more likely caused by significant straining on the toilet, significant constipation.
Okay. I got these two questions asked in the message. So can hemorrhoids be an early sign of colorectal cancer, and what can we do to reduce our chances of colon cancer and hemorrhoids?
So hemorrhoids are not an early sign of colon cancer. They're a completely separate process. It's more of like there's a lot of vasculature, veins and arteries throughout our entire body. And specifically, hemorrhoids are dilated veins that occur in the rectum near the anal canal, and can sometimes come through the opening. They can bleed, and this is a symptom that's also possible in a cancer. So that's why it's always hard to distinguish whether bleeding is solely coming from a hemorrhoid or if there could be an internal process. And so usually when you go to see a doctor, depending on your risk factors, whether you smoke tobacco, whether you eat red meat, whether you have a family history of colon cancer, your age, there will be some sort of discussion of an endoscopic evaluation. And that means specifically putting a scope up your bottom, either a flexible sigmoidoscopy, which is a half colonoscopy, or a full colonoscopy. Typically, anyone above the age of 35 that comes to see me, I'll typically advocate for a full colon. And less than 35 without any other significant risk factors, we'll talk about the risks and benefits of a flexible sigmoidoscopy versus a full colonoscopy. And, I'll help them come to the decision that's right for them.
Yeah, and just to kind of reinforce, all the pictures we show today are of the anal canal and anal lesions, anal cancer. Anal cancer and colon cancer are two completely separate kind of diseases. They're caused by different risk factors. Colon cancer has no relationship to HPV infections. So those are the etiology of colon cancer and anal cancer are completely different.
All right, so another question from the chat. So is the exam, so the rectal exam, can that be done by a PCP, or do you need to be referred to a specialist to have it completed?
You could have it, from my standpoint, you can have it done by a primary care physician as long as they have the instrument, they're comfortable with doing it. But you do need some familiarity with it. So probably if somebody's doing it, they probably do it on a routine basis. Yeah, otherwise, we do get a lot of referrals just because a lot of primary care physicians and other family care doctors may not have instrumentation, and they may not have a table to kind of get them in the right position.
Okay. Thank you for that. Are LGBTQ plus individuals at a higher risk for developing colorectal or anal cancer as a result of high tobacco and alcohol use within the community?
So not alcohol, but there's increased risk in people who smoke. So LGBTQ community. So one of the things I mentioned was anal receptive intercourse. That's kind of one. And otherwise, HIV infection is another. And smoking is another one, but not alcohol. So that increases your risk of getting anal lesions and its progression.
Okay, so we have a few individuals on the call who are currently in medical school. And so one person asked, could you please share any important tips or considerations to providing the most inclusive / gender affirming care to our future patients?
I think that Duke has underneath their name and medical record number, they now have pronouns. And so I think that's very useful to always take a look there and kind of remind ourselves how this person would like to be addressed, whether they're male, female, they also have that as well, male, female, queer, gender fluid. I think these are all of the terms that are possible. And so when you do your documentation, making sure that you're appropriate in that, when you're speaking to the patient, making sure you're appropriate in that, and just making sure that you don't have a bias coming from yourself. Like, try to be as open and equal to everyone that you're treating. I think that, I've had a few individuals who were transgender, and they definitely expressed to me that they felt that they got different care than their non-transgender friends and family. And so I think it's very important to know and treat them equally and make sure that you don't treat them any different than you would any other patient.
Yeah, and I think this is the last question we have time for. So I would be curious to know is why is colorectal and like other types of cancers that we talked about today on the rise in African American and LGBTQ plus populations?
So I would say that colon cancer is at an elevated rate in African Americans, and I think it's more of a genetic predisposition, as well as, there are two known risk factors that we can reduce, which includes tobacco use and the ingestion of red meat. So if we can, those are definitely known risk factors. I think that the incidence of colon cancer above the age of 50 is going down. However, the incidence of colon cancer below the age of 50 is going up. And it's going down in people above the age of 50 because we have colonoscopies in place, because we have other colon cancer screening strategies in place, including Cologuard, FIT testing, CT colonography. So we have ways to determine if people are having abnormal signs, symptoms, and we are actively screening them, looking for these things before they turn into cancer. Versus I think the incidence is rising in people under the age of 50 because those are the people we are not screening. And so when they do show up, they end up showing up at a later stage. And so we don't catch them when their cancer is a polyp, we catch their cancer when it's a cancer. And this is why the age has been reduced from 50 to 45 to start colon cancer screening in an effort to try to track down these people who are developing colorectal cancer at a younger age. I also think it's very important that if you have a family history, to make sure that your primary care physician knows about your family history of colon cancer, because sometimes we do start screening those people at the age of 40, and if not, 10 years actually younger than the first individual who was diagnosed with the cancer. So say your dad was diagnosed with cancer at 38. So we wouldn't screen you at 40, we'd actually screen you at 28. So we do 10 years younger than the first degree relative. Just important things to discuss with your doctor.
All right. Thank you so much for taking the time out of your busy schedules to come and talk to us and answer our questions today. So I do have a few resources to share with the group before we close out. The Community Outreach Engagement and Equity Office specializes in patient navigation. And so we tried to connect North Carolina community members to sustainable cancer screenings through primary care providers and medical homes, through federally qualified health centers, free and charitable clinics, and local health departments. And we also provide cancer outreach and education, such as this event. And so we have a community health ambassador program which I just completed last week. And so if you are interested in that, I implore you to sign up for the next one because it's a great training and we have some great patient navigators who lead that training. And we also have monthly cancer awareness webinars and then community health fairs, events, and meetings. And these are some of our patient navigators. Some of them are on the call right now. So we have Lasagna, Nadia, and Mary. You can reach out to any of the three of these individuals and they will be able to connect you to the care that you are seeking, or if you're seeking it for someone else, they can connect you to that. And our next event in the series is going to be on June 29th of this year. And it's going to be a talk with a member of the National LGBTQ Cancer Network and also a survivor of cancer. And they're going to come and talk to us about how we can make spaces more inclusive for the queer and sexual gender minority communities. And so this event is open to all. It's a national event. And we are calling on providers. We're calling on future providers. We're calling on patients. We're calling on family members to come out and learn how to create inclusive spaces for this community. And once again, I would like to thank you all for joining us this evening. If you guys have any other questions, please don't hesitate to reach out. I can connect you to any of the patient navigators or either of the two presenters if you have any further questions about the information that was presented today. And we thank you and hope you have a great rest of your evening.